Hello, everybody. We're going to be talking to Dr. Kochar today, who will be talking to us about an article that he wrote in JACC on taking care of the older patient in the cath lab. Dr. Kochar, thank you so much for joining us here today. Tell us a little bit about the motivation behind this article.
Dr. Prasad, thanks so much for chatting with me today. It's my distinct privilege to chat with you on behalf of a truly wonderful and collaborative co-authorship team led by Dr. Damluji and Dr. Al-Kaloui. Essentially what we were interested in is really emphasizing the difference between chronological age and biological age and how that impacts how we think about caring for patients in the cath lab across the spectrum of interventions that we do. So coronary, peripheral, and structural as well.
And that's a really important consideration. So can you tell us a little bit about what your article says and to summarize it for those of us that may not have read it?
Yeah, absolutely. So, to delve into that initial concept, chronological age is just really a linear construct that just goes along with time. But biological age reflects all of the differences that happen on a molecular and cellular level and then manifest them on an organ level over a time. And there can be pathological aging that occurs because of that. And so I think one of the things that our team wanted to emphasize is that we all intuitively know this, right? When we walk in and we do sort of this bedside test, where we look at a patient and we say, gosh, that patient looks a lot older than the 75 that's designated on their age. But what we would argue is that it's really important to try to quantify this. In the manuscript, there is a very long table of the different ways to quantify biological age. But I would simplify it by saying, there's probably 3 or 4 key domains to think about. And one thing to think about as a construct there is this patient prone to some kind of geriatric syndrome? So one of those syndromes is frailty. And frailty is essentially defined as an aging-related biological construct that denotes that an individual is prone or vulnerable to an acute stressor. Like their ability to bounce back, their bounce back ability is much poorer. And you can quantify frailty in a variety of different ways. Prospectively, you can use something called a Fried phenotype that looks at 5 key characteristics. There's a cumulative deficit model that was developed by Ken Rockwood and colleagues that initially actually took over 90 variables, and then it's been cut down to about 30 variables, and it's a ratio. So if you have 10 out of those 30, then your cumulative deficit index would be 0.3, and that would correspond with a certain degree of frailty. What's interesting about this is, like with anything, I think making it easy for us as clinicians or busy interventionalists will be key. And now there are even electronic frailty indices that can leverage the comorbidity indices that you have already available in your electronic health record. And so it'll be interesting to see if we can start getting access to that. In fact, in the VA systems, they have access to the VA Frailty Index or the VAFI. And so hopefully we'll see that, and not just across the US, but globally as well. A different construct from an aging perspective that I think is really key to think about is cognitive function. And there are some estimates that about 1/3 of patients that come to cardiology clinics have some degree of cognitive impairment. And so then when you think about these and you've identified them in a systematic way, then those factors can then inform risk benefit discussions, especially when it comes to sort of higher risk procedures that we may take. On the note of frailty, our group has published some work actually that has showed that frailty isn't just a categorical variable like you're frail, not frail. It's a continuous variable. And so patients who are severely frail, really their risks exceed almost exponentially. And so again, quantifying this will be very, very helpful.
That's fascinating. Sorry, go ahead.
No, I was just going to say, we go on to sort of detail sort of how to think about this in sort of the various different factors that we approach or disease processes that we approach in the cath lab that I'm happy to delve into. But I rudely interrupted you, so go ahead.
So I was just wondering, you have probably some research projects that are in the pipeline then, it sounds like, in terms of quantifying frailty and quantifying these things in the cath lab before we take a patient in. How do you see that fitting into our workflow? Is that something that the referring cardiologist will do? Is that something that we'll be doing in the pre-op setting? How do we incorporate that into our workflow so that we can apply this to our patients?
Yeah, all great questions as always, Dr. Prasad. So I think, one interesting concept is that if we look at frailty specifically, frailty may be a dynamic process, meaning that you can potentially reverse some frailty. So for, very elderly patients potentially undergoing TAVR, there is a possibility of implementing, instead of, post-procedure cardiac rehab, but rather pre-procedure prehab, and really optimizing them prior to the procedure. So there's some studies that may be looking at that and what the role is there. I think zooming back and just thinking about older patients that we're caring for, they tend to be extremely underrepresented in most clinical trials that we've done. And so I think as we're doing designing clinical trials, being more deliberate about including that cohort of patients, because they are prone to unique issues and often higher rates of complications. The other thing, as we're designing clinical trials, to think about is older patients often have different preferences. And so thinking about endpoints that are sort of oriented towards older patients, like oftentimes what they care about is, can they maintain independence? Can they minimize the time in a hospital? There's some data that suggests that they really feel strongly about avoiding strokes, for example. And so thinking more about quality of life metrics as a key endpoint of clinical trial in older adults may be reasonable. And then the last thing to think about in an emerging field referred to as geroscience is that there are some gero potentially therapeutics as well. Some of the drugs that are being considered to reverse aging as a construct are things that we as cardiologists are familiar with. So there's some studies thinking about using metformin, SGLT2 inhibitors may have a role in reversing aging. And then there's some novel agents as well. There's some TOR inhibition. So there's a lot of sort of interesting work that's being done in that space.
That's all fascinating. Well, thank you so much, Dr. Kochar, for speaking to us today. I know that as I read your article and came to the cath lab, I was already looking at my patients with a slightly different lens. So I hope all of our viewers read your article and begin to apply this to their patients so that we can better start to risk stratify these patients as we take them to the cath lab. Thank you so much for speaking with us today.
Absolutely. Thanks so much, Dr. Prasad. Cheers.